If you have questions, please stop, please ask. I do not mind questions. It does not upset me, okay? If you're not understanding it, then I need to know what I need to do to explain it a little better for you, okay? So here we are, only weeks 4 and 5. It's 3 chapters. But boy, is it loaded with a lot of stuff. So, first of all, there's always vocabulary, and this is just this memorization of the definitions. So, let me try to explain them in another manner to you. Conscious sedation. This is something that I've used in the ER when we've had bad fractures of usually just wrists, both bones, and they have to set it. What they do is they give a medicine that knocks the child out, but they're still breathing on their own. And they don't remember. We put the cast on, set it, and they wake up and they can go home. So it's IV drugs, impairs the consciousness, but retains protective reflexes, which means they can breathe, the ability to maintain their airway, and the ability to respond to physical and verbal stimuli. I always tell the child, go to the beach, go play basketball, go to your happy place and think about it. And that's conscious sedation. Clinical pathway is that interdisciplinary plan of care that basically shows what's going to be going on. Clinical pathways are those common type of diagnoses. One might be an outpatient procedure, tonsils. This is what you do pre-op. This is the instructions you send home. This is the doctor's orders. Every person gets the same thing. That is their pathway. We know what orders are coming next. It's already written. An emancipated minor is an adolescent who has gotten legal authority to sign for themselves and their own children. It could be a 16-year-old who's not living with mom and dad, who is now having the ability to sign consents. Because we know you can't sign a consent until you're 18 and you're cognizant, you're aware, you're alert, and you're oriented. Regression is that loss of an achieved level of functioning to a past level of behavior, and that was successful during the early years of development. Well, regression is always when a child's stressed or upset. This is part of your separation anxiety, right? The second stage is where they regress, start sucking their thumb, they become incontinent, they need a diaper, they want a sippy cup, not a regular cup. That gives them the feeling of comfort. That's regression. That's when they usually do it. Now, there are 2 different diagnoses, and they're always mixed up: meningitis and encephalitis. Now, think of meningitis as the meninges, and it covers the brain and the spinal cord. Okay. This is, one of the infections that causes meningitis, or that inflammation of the spinal cord and the meninges on the brain is group B strep. That's one of the big bacterial meningitis we see. But encephalitis is only the brain, cephalic. What is cephalic? That is the head. So it's only inflammation of the brain, okay? Don't mix them up. Osteomyelitis is an infection in the bone. Could have stepped on something, got stuck in there, and went to the bone, big infection, redness, swelling, and pain, fever. Osteosarcoma is a malignant bone tumor. A lot of times this is the femur bone, and they have to get their leg taken off because you can't just remove a piece of a bone. Rey syndrome is when we give aspirin to a child and they react to it, and it's called Rey syndrome. It's an acute non-inflammatory encephalopathy and hepatopathy. It's the liver and the head get all inflamed from it. They get very sick. So one of the things with aspirin is we never give it to a child. There's only one diagnosis that you'll hear me say, and that's the cardiac week, which is, I believe, the week of the exam next week. So no aspirin. Sepsis or infection, being sick, running fever. Sepsis is that systemic, which means all over the body. It could be due to a bacteria, could be a virus, or a fungal infection. And that can lead to shock and death. So sepsis is due to all of these extra things that our body doesn't like. Okay, go back to Freud. Freud, anything sexual, okay? Remember, oral is that infant, anal is that potty training toddler, phallic is that time where they're starting to see that they have differences, with their genitals, boys like moms and girls like dads. That's what that means. And then the weirdest word of all, latency. Why latency in Freud? All they're saying with the sexuality is that children now are relating to other children of their own age, and it's usually same sex. And then, of course, you become an adolescent, and it's all about the puberty, right? Going there and getting excited, and other children and whatnot. You know what I didn't do? I didn't turn on my video. I wanted to say hello. Let me keep going. Sorry about that, guys. Okay, so Freud's again, this is just telling you the same thing, what I just said to you. Now, Piaget, reliving this is all about the way they think and they understand what's going on around them. We know at first, it's you understand that if you cry, the baby comes. And pre-operational starts thinking about words and things, and a broom it is a horsey, and leaves have trees, and they protect the tree from getting wet. I mean, they're imaginative things. The concrete is that something solid, something that a child knows, understands, and does really well. That's that concrete. And they're able to use those things. So they've seen it before, right? And now they can do it themselves because they've seen it. Formal operations is they can think it, they don't have to see it, and they can figure it out. I always relate that to the adolescent who mom says they can't go out Friday night because they did this, or whatever. And what does that adolescent do? Anything they know that will make mommy happy so that she'll change her mind and let me go, right? Nobody taught her that, but they're going to do it. So there again is some more. Sensor motor is, senses, that's that crying. That's that object permanence, right? Hiding a toy, but even though they're not in sight, they know the toys are around. They're pre-operational. Again, animals have leaves and they're not getting wet, the trees, all of these things. Concrete one, again, it's why you have to understand, you have to see it to understand it. And then formal, they can figure things out. Erickson, you're going to see going forward, you're going to see it on your HESI and absolutely your NCLEX, probably the most of all of them. Remember, infants, all about trusting. Mommy comes, somebody comes when I cry, when I'm screaming for them. They come right away. Mistrust would be when, there's some reason why continually they're not coming to get them, not just once, okay? As we go forward, remember, toddlers, autonomy, automatically me, mine, right? They don't share, and that they want to do everything themselves. What is the shame and doubt? Well, that's when mommy or grandma's that helicopter behind them doing everything for them, and don't let them fall, don't let them dry, and they get shame and doubt. We've got to let toddlers try to do things unless it'll hurt them. And as we go forward, let's just go now to the school age. School age is all about what I do well and what I can't. School age children love to do something really good and get praise for it, but feel inferior because they can't do everything. And of course, what are the adolescents? Who am I? What am I going to be? And all the confusion that goes with it. So this is exactly all of these sort of things. Goes into some more the toddler self-feeding, self-dressing, how to talk, how to express themselves. Preschoolers initiative. They want to do stuff. Getting a pet, plant, fish, those things are actually really good. And they need to know if they do something wrong, that Kohlberg comes in, that reward and punishment takes over at that. They get a pet, they have to take care of. If they don't, they're going to be corrected. Again, school age is what they do well, and they love that recognition. And of course, adolescence is who am I? What am I going to be? And being comfortable with it. Maslow's will always be a part of this too. We need to know the bottom is what do we need to live? We need food, we need drink, we need sun, we need sleep, we need to be bathed, right? Well, then it goes up to the top in esteem. And what is esteem? Well, your child is good at baseball. Well, enroll them in baseball so that they can go and practice and show how good they are. And then, of course, all the in betweens there. Kohlberg is all about morality, morals, right, wrong. Now, infants and preschoolers don't really understand as much. What it happens is right at preschool is where they understand I did something good, I got a reward, whether it's a hug, whether it's a verbal or a present, whatever. And punishment, I did something bad, and they understand that well. School age children want to please. They don't want to do wrong. They like to please authority. And then Kohlberg in the adolescent is all about doing all the right things in public. You go out in the public, you're going to dress properly. You go out in public, you'll hold the door for someone. You'll stop at the red light, the stop sign. What your public has as rules, and you follow them. Okay, hospitalized children. So when does discharge planning begin? Well, the moment you see them. That's why as I'm doing assessments and listening to children, I'm talking to the child, no matter what age, but it's because the parents will be listening, what I'm doing, what I'm listening for, and what do I hear? To decrease stress, the biggest thing to do is the parent stay with the child, especially when you talk about toddlers. They do not want to be left alone because then they'll go through that separation anxiety. Trying to incorporate routine and mimicking what we do at home, as in, if we can, the types of foods, if the diet allows. When do we give bath time? When do we take naps? Changing their clothes. I mean, we could change the jammies in the morning, right? All of these things, keep them in the same. When do I play? When do I rest? When do I eat? What do I eat? Now, an altered level of consciousness, or LOC, level of consciousness in children, can be caused by a low blood pressure. Now, why is that? Well, if your blood pressure, the blood's not pumping the way it should, how are you getting oxygen? And don't you need oxygen to think and to be alert? Because remember, if you're hypoxic, you're getting restless and confused. So, low blood pressure, symptom of an altered level of consciousness. So, goals when caring for hospitalized children, some of the goals: always keep the parents in the loop. I have parents watching my children. They're my eyes, my ears. I can't be in that room 24 hours a day. And that parent, when you're reassuring them, this is what I'm teaching you. They're telling you what you've just said. You are, teaching, which is what you want, but you're reassuring them, giving them a purpose. And that's what they don't want to lose control. Maintain a sense of trust with that child. Even young toddlers, they will remember, they don't forget a thing. So if something's going to hurt, say, it's going to hurt a little bit, but we'll give you medicine. And I'm going to sit here and hold your hand, but it should go away soon. Or I can give you more medicine if you need, or let's just sit, let's put ice on it. Whatever it is, be honest, because I'll never trust you again. And this is really true. Remember, every child is different. every child reacts the same, and every child's treatment plan, this is why I love pediatrics, they're really no two the same. In the adult world, yes, they're most, this is going to happen. You've had a gallbladder taken out, da 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 da, same thing, everyone. Children know. So remember, you have to be flexible and individualize your care with children. Always try to incorporate those home habits and those objects that, my grandson, he liked this little beanie baby that was a giraffe. He called it Mr. Puppy. It was his security blanket. And he had one blanket that he loved the texture. And when he had those two things, he was really, really happy. And when you're in a weird environment, these help keep that home routine and keeps them happy and decreasing their stress. As you're playing with a child, use those soothing techniques to try to help them with things like those threatening experiences. Just the blood pressure can be threatening to a child. So you would let them touch and feel the equipment, maybe push the button on the machine or do the nurse first yourself and then say, "Oh, I got this number. Let's see if you can get that number." And again, that's soothing, it's using play, and it decreases that threat. Make sure you use appropriate play activities for children of different ages. Remember, number one is always safety. If you have a cognitively delayed child, make sure safety is number one, because a child of the same age that is not cognitively delayed, maybe it's not a safety issue, but be very careful. It's one of the big things with playing and toys, safety. Now, let's say you have a child who's been in the hospital, had abdominal surgery, they're 1 year old, and they haven't been able to get up and out of bed, and 2 weeks later they can. Well, help restore to normal growth and development stages after surgery procedures. Well, what should they developmentally be able to do around 1 year? Walk or attempt to walk to take steps. So get them up, try that. They should have blocks of stack of two. Give them blocks. This is what this means. Help them restore it, be aware of those things. And get them up and out of bed. And of course, each age group is different and know what you have to do for each. So parent involvement, separation anxiety is a big, big thing. Many of you have children, know the first time, even at young babies, you take them to a new place, they're going to scream and cry. It breaks your heart. You don't want to leave them, but it is a normal part of it. So, of course, parents should be involved in it, understand it, so that they know what to expect with children. Starts about 6 months, and at 10 months, it's really, really peaks. Okay. So we've done that discussion question: protest, despair, denial. Know the names of the three stages. Protest: screaming, yelling, going bonkers, mommy, mommy, mommy. And they cry and cry, and finally they usually just fall asleep because they're exhausted. So mommy's not there. As nurses, what do we do? Well, try to have consistent caregivers. Some mothers have to work, can't get in for 2 days, and it's not because they don't want, it's because they have to work, they have other children, and they don't have a partner or anybody to help. And that's a reality. So using consistent caregivers, whether nurses, assistants, doesn't matter. That goodbye ritual, don't let it continue too long. It just makes it worse, okay? And one of the big things is distraction, especially like a toddler, maybe giving them a toy that they like, or putting on a cartoon, or giving them your phone, right? iPads, letting them something to take their mind off of it. And then always, yes, mommy will come back. She's with such and such. I just spoke to mommy. She sends a hug. Let me hug you for your mommy. And that helps. Well, then after they realize that they're there and mommy's not there, the despair occurs. And this is the regression part. They look sad, they look depressed, and they look withdrawn. They don't play. They just are really sad, okay? Start sucking their thumb. This is when they might become incontinent, etc. Now, what do we do? Well, what you're going to do is if they have their little Mr. Puppy, like my little Christian, my grandson, go in there and start playing with Mr. Puppy. Or, oh, the blanket was on the chair. Let me put it in the crib with the child. So he has that. And, play with the kid with things that are age appropriate, right? But again, remember, kids get cranky and angry when they're tired and they're hungry. So make sure that we do these sort of interventions when they're at that more alert and, not tired or hungry and cranky, right? And then let's talk about things, especially as it get a little older, about something fun when the parents return. Sometimes I have them color a picture, give them crayons if they're old enough. Mommy gets a note when she comes back. It gives them something to think about instead of just mommy's not here. Well, then all of a sudden they're like, oh, they don't even care if mommy's there anymore. They become detached. Mommy shows up and they just are not interested. They're more interested in their surroundings and toys. Why? They don't want to be hurt again because they know mommy has to leave. So that's why they do it. So when the parents come, if you've been that consistent caregiver, you know, be there with the child and the mother and try to encourage, oh, we made this color picture for you. And, we chose the colors and whatever. Just try to start that rapport again. Pain scales are very important. You're going to see them scattered throughout all the exams and HESI, absolutely your NCLEX. So the two big ones in pediatrics is FLAC and the FACES. Now, FLAC is for those young child less than 3 years old and nonverbal children. Could be an 18-year-old cerebral palsy child who's nonverbal and they can't talk. You would use a FLAC scale along with an infant. It shows the faces, the legs, the activity, the crying and consolability, and it works really well. I've used it, for years in the pediatric area, and it's quite accurate. The faces from 3, onward up. And at 8, it's that numeric from 0 to 10. Tell me where your pain is. 0's no pain. 10 is the worst pain in the world. Well, at age 3 and higher, they can look at the pictures of these faces, tell me how much you hurt. And you know what I love about children? They don't lie and they don't over exaggerate. They're going to point to the picture they absolutely are. An adult's going to tell you their pain is 20, and that little child might look and say it's an 8. And you're like, and your tears are just pouring down that poor kid's face. These are the two pain scales. Now, also talking about pain, what is pain? Well, pain is whatever they say it is, whatever number they say it is, okay? It is not what you say. The kid is sitting there crying, laughing and joking, especially older kids. It might be their way that they deal with the pain, okay? Back in the early 2000s, like 2002, the Joint Commission said that we weren't documenting pain scales enough. So we made it the fifth vital sign. So it's not just your temp, pulse, respiration, blood pressure, it's your pain scale. So we do it every time vital signs are done. Now, what's the best way to administer pain management? Let's say that your child just did have, their appendix removed, so you know that they're in pain. Well, the best is when you use low dose analgesics, administer around the clock. Don't wait for PRN. Just give that low dose, okay? And that keeps them with that pain control. As it's the second or third day, you can decrease it and then make it PRN. But initially, that's the most effective low dose analgesic around the clock. Now you're looking about acetaminophen, mild to moderate pain. Children have never taken pain medicine. They have no tolerance for anything. Acetaminophen works extremely well. In fact, today for tonsillectomies, we're sending them home just on acetaminophen. Years ago, they sent them home on a codeine liquid pain medicine. They don't need that anymore. We found they were overdosing on it. Acetaminophen is fine. Now, when do we use opioids? Well, fractured femur. I mean, if I broke my femur bone and had all those muscle spasms, I would do that. Postoperatively, appendectomy is going to get some morphine or Dilaudid, whatever the child can get. Sickle cell crisis, that child is definitely going to get an opioid when they first come in until we can break open that clog of cells and get that swelling and pain to decrease. And of course, with cancer, cancer can be very painful. So opioids, moderate to severe, acetaminophen, that mild to moderate, and actually acetaminophen, opioids, alternating them is the best to keep them really comfortable. Now, putting in sutures, giving an IV is scary. They're needles, they stick, they pinch, they can hurt. So we can use a topical anesthetic. We use lidocaine in all different ways. We can have sprays, we can have creams, we can have jellies. All of them are great to use. And telling the child, you're going to feel touch, but you're not going to feel anything, any pain. And you don't if you, of course, leave it on for a little bit before you use it. Again, conscious sedation, they're not awake, they're not alert, they don't know what's going on, but they breathe on their own. And if you need to talk to them, they can. Now, flumazenil. Does anybody know what flumazenil is? Do you remember that from pharmacology? If I said diazepam, midazolam, any benzodiazepine, it is the antidote if they've had too much. Flumazenil. And then opioids. What is the antidote for that? So those are two things.
Narcan.
Okay. Narcan. Good job, Emily. Great. Or naloxone. There's, the different names, but yes, very good. So, eyes. Pink eye conjunctivitis is an inflammation, itis of the mucous membrane. Kids are always touching everything and everything's in their eyes, and this is part of conjunctivitis. They put in creams or lotions, or not lotion, creams or solutions into the eye. Remember, if they use that ointment, please inform the child. He's going to be a little bit cloudy, and once it melts, he'll see okay, because they'll get really scared about, I can't see, and they'll be scared. We don't want that. Hyperopia is farsighted. You can't see near. And why they do that opposite, I don't know. Myopia is nearsighted. You can't see far. Now, amblyopia is a lazy eye. One eye is up, down, crooked. It doesn't go straight ahead. Now, how do we treat it? Well, the muscle is weak in the lazy eye. So if you put a patch over the good eye, off and on during the day, you make that left eye muscle work. And that actually strengthens it and helps it get straight without any other treatment. Strabismus is another word of cross-eyed. So you put your finger out and one eye gets there and the other one just can't get it. Their eyes don't work on the same way. So you have one eye looking over here, one ear, or it could be cross-eyed of that sort. Nystagmus is this jiggly twitching type of jerky movement of the eyeball, nystagmus. And papilledema is when the optic nerve gets swollen. And again, you'll see some vision sort of symptoms. Ears, types of hearing loss. Very important. Congenital, you're born with it. It could be hereditary or an infection into utero that's, come out and, the hearing is now lost. Sensorineural, it's when there's damage in the cochlea, the nerve, and it's you can't hear because of it. So it is a physical damage. And conductive is when something prevents the sound from the membrane to go into the middle ear so that you can hear it, because you need that sound to go straight through. Now, what would you do for a hearing impaired child? So they can't hear, but they can see and they can talk. Now, make sure that you're looking at the child face to face. They can't hear, so they can see your lips moving. Eye level with the child. Again, we don't want to be above them. That's part of our initial just doing an assessment on them. Look at them in the eyes and talk in short sentences. And do not yell. Okay? They can hear. They maybe they can hear slightly, but that yelling, it sort of over emphasizes the way that you're talking. Just talk normally. Don't try to over exaggerate little short sentences. So we have two sorts of otitis, media and externa. Well, externa is just the external canal. Usually it's called swimmer's ear, and it's painful. And we just put eardrops in there, and that helps. Now, otitis media is an acute infection, inflammation of the middle ear, and that child is going to point to it and tell you it hurts. They'll be holding their head. May or may not have a fever with this too, also. How do we treat it? Antibiotics. We're going to give what? Amoxicillin, be a good one. Now, seizures. Simply, what is a seizure? Some piece in the brain, all of a sudden, a spark happens and zzz, and then you're going to see some sort of physical response. It's like, zzz, zzz, like, what happened here? We don't know why seizure happens. I mean, it could be medications and stuff, that could be, but a child who, has a seizure disorder, there's different types that we'll discuss, okay? Now, grand mal is also called generalized tonic-clonic. This is the one that you think about when you have a seizure. Arms and hands are going, foaming at the mouth, and you lose your bowel or your urine, okay? And then when you wake up, you have this postictal or a confusion at the end of it. So it takes a while for them to come around. They're confused. Now, petit mal could be as simple as you're talking to someone and it's like they cloud over and they don't hear you. And then all of a sudden they go, oh, what did you say? It's, like a blank stare. And it's a couple seconds. It's not long. Now, Jacksonian could be just an arm twitching, a leg twitching, could be your cheek, could be an eye, and the child patient is still awake and alert. Myoclonic is or atonic seizures. It's jerky motions on awakening. And then all of a sudden, they collapse and they wake up after 10 to 60 seconds, up to a minute long. Myoclonic. That's really a hard one to diagnose there. And then status, anything status asthmaticus, status epilepticus, something that lasts and lasts and lasts and lasts a long time, and they don't respond to it. I've seen many of them where we're giving medicine for seizures, we're giving that lorazepam or Valium diazepam, trying to stop it. But status is more than 30 minutes. And then again, postictal, I said, usually following grand mal is a area where they're confused and they need to sleep after this seizure. So what causes seizures in children? Look, all of these things: an infection, fever, drugs, epilepsy, hypoglycemia. And yes, low blood sugar can cause hypoglycemia, especially in your younger infants. I've seen it occur. So all of them, something to remember. So you have a child admitted, new seizures, old seizures, it doesn't matter. You need to have them on seizure precautions in case they have one, right? So they're in bed, side rails up, or in a crib, rails up, so that they can't, have a seizure and fall out. If there's areas in the bed that are sharp It needs to be covered. I can't tell you, sometimes I take baby diapers and we'll cover, and yeah, those little tabs that we can put them on to cover the ends of the beds and sharp areas, because when they have a seizure, they're rubbing on it and they can really, scratch and cause lacerations. Parents need to know that these children need to wear a medical ID bracelet. I mean, older children can have it on their phones, but they need to be identified that they are seizure patients. And of course, with that, any allergies with it, because if medical help comes, they need to know what they can give. Also, teaching parents and then older kids importance of compliance, making sure they take their medicines like they should be doing. This is probably the biggest cause for seizures breaking through because, oops, I forgot that dose, or oops, I didn't get to the pharmacy and refill my prescription. And one thing that I don't think we think about is if you have a child that has a seizure condition, you don't want them somewhere where you can't get to them if they're having a seizure, like in the middle of a pool, in the middle of a lake, in the middle of the ocean. They have a seizure, they're there alone, and you're not there, they will drown. Okay, so make sure they have supervision when they're doing these sort of things. Now, the treatment all depends on what type of seizure. If it's a febrile seizure, we just need the parents to know that they see a fever, they need to medicate, because it's, you see a fever starting to happen, you medicate it, you bring it down. They're not going to have that seizure, but that's very, very hard to do with febrile seizures. Other medicines, what do we use? Why? Well, it all depends. And there's usually multiple attempts to figure out. And the biggest thing that we look at is the side effects of the medicine that we're giving the child. We want the least amount. So the covering of the brain and the spinal cord, we know that is meningitis, right? Spinal cord and the brain. We know that one of the most common things is Haemophilus influenza, and we know strep is in there too, okay? So if it's bacterial, we know that there are they release toxin, it is airborne. We can get it. So they're on droplet isolation for 24 hours. And after 24 hours of getting antibiotics, we can take them off of the droplet. Okay. Also, with bacterial, we're going to see this petechiae, and we know that's meningococcal. We know that that's what we're going to find. So, you see a child having the symptoms, the headache, the stiffness, the fever, those things, put a mask on yourself, get that child in a mask, get them into a room where their droplet can't go and get other children and getting them ill. So neurological checks are going to be done. It's an inflammation of their brain. So there's a lot of pressure in there, right? So we're doing neuro checks, looking for the weakness, speech problems, mental confusions, or all of a sudden their behavior changes, making sure that we check their vital signs, fevers, of course, looking at intake and output. Again, fluid balance and pressure in the brain. We don't want them overloaded with too much fluid. And one of the things is their brains are so irritable, noises and lights bother them. So put them in a quiet environment. It decreases stimuli and it will help decrease a seizure that they might have had due to this noise or the environment. Okay, let's look at fractures, sprain, strain. So we're talking muscular skeletal stuff. So these are just definitions that you should know. Green stick, it's an incomplete fracture. One side of the bone is broken, the other is bent. So you have a bone, one has a little fracture, and then you see a bend in it. Green stick. Compound is when it's pounded out through the skin. So now you have an open wound with the bone sticking out. Big problems with that is worrying about infection. Okay. Simple fracture, most kids' wrists, right? Fell down, one of their bones has a crack in it, and that's a simple fracture. It's not displaced anything, put a cast on it, let it heal. Oblique is when it causes an angle across the bone, not straight, but an angle, and it cracks. Now, child abuse, a lot of times we can determine child abuse by a type of fracture. Now, a spiral fracture, you twist. Sometimes children, you grab their hand and you twist them hard, it can crack their bone. You can also take the leg and twist it hard, and they can fracture the femur. This is an absolute reason why we can look at, say, we have to be considering child abuse here. Remember, with child abuse, it is us as nurses' responsibility if we suspect to report it to our charge nurse and to the physician. It's better to be safe than it is to be sorry. Now, a sprain, I've had 100 of them, especially playing volleyball. So when the ligament is torn, stretched away from the bone, the point of trauma resulting in damage to blood vessels, muscles, nerve. Come down off of spiking a ball, my leg would go twist, and I would just twist my ankle, and you would hear it rip, and it would swell up, and it would turn in this massive purple area. Of course, we treat that by RICE, right? Rest, ice, contain, and elevate. Now, strain is like you're riding a bicycle, and you get these microscopic tears. Gymnastics, doing the same, those people doing the same thing repeated over and over again causes these strains. And then a contusion is just where you've bumped into something, you've been hit by something, and you'll see that hemorrhage, edema, pain, ecchymotic area. So those are the type of fractures, and those are pictures for you if you didn't understand what I said. Now, things with bones, scoliosis usually happen in that young adolescent. One of the shoulders, you'll see, number one, S scoliosis. It's an S-shaped curvature of the spine. And what you see is one shoulder will be up over the other. And you'll see when they bend over, one arm is longer than the other. So those are some of the ways that we look at scoliosis. Ewing's is a cancer. It's a sarcoma, and it's in the marrow of long bones. Leg calf girth. It's a disruption at the end of the femur bone and the development of the head of the femur. And it creates a lot of pain and a limp in children. And it's aseptic, which means it's just something that happens, and it just needs rest to treat. Now, JIA or JRA, they've changed the name from rheumatoid arthritis to idiopathic arthritis. And what it is, it's autoimmune. It is your body doesn't like joints, connective tissues, and viscera, which means, into your abdomen. And it causes swelling and pain. Now, oligoarthritis affects 4 or fewer joints. Sometimes you have the whole body will bother you. Sometimes it's one place, and that would be an oligoarthritis. I've already said osteosarcoma is cancer of the long bone, usually your femur. Now, Duchenne muscular dystrophy is only in boys, and it's a progressive muscle degeneration, progressive weakness. And what happens, their calf muscles, they look like they've overexercised. There's big, big calf muscles on them. And over time, the progression of that muscle weakness occurs, and they usually die from either heart failure or they stop breathing. You were talking about the diaphragm is a muscle and the heart is a muscle. So it usually, and it's boys. Torticollis is when you get that kink in the neck. And it's the sternocleidomastoid muscle gets shortened and it causes pain, and you need to treat it, what, heat, cold, exercise to get it better. Now, fractured femur, the long bone in the upper leg. When it's broken, it will detach, and the two ends with the sharp edges will go right into your muscles in your thigh, and it hurts. Okay, swelling occurs. So what they do is they take traction, and it's just a boot. It's no needles, nothing like that, and they strap it on, pull that femur straight. So now we've prevented all of those icky stuff, from attacking those muscles in the thigh, and pulls it straight. And it goes down, up, over a pulley, and down, and there's weights on the end. Those weights and that pulling needs to be all the time. If you take it off, that femur will dislodge and you're in pain again. Now, what is your nursing responsibility? Make sure you're checking the pulses and the neurovascular signs of the feet, because with that femur broken and the swelling, it can occlude blood flow. All right. All right, made sure I covered it all. So the purpose of traction is to retain the normal length and alignment of the bone, immobilize it. The big thing is to eliminate those muscle spasms and to relieve the pressures on the nerves because it is painful. Also, when we put it back to where it needs to be, you're going to make sure, and it's going to reduce the chances of skeletal deformities and muscle contractures, because you want the legs to be the same size. So what are we looking for? Well, not only we're looking at neurovascular signs and pulses, we're looking for, has the pain increased a lot or is it the same? Is the pulse there? What's the color? Because they should be pink little toes. If they're turned white or paler, we have a problem. That means blood's not getting there. Paresthesia, numbing. Is it becoming numbing? Or can you move it? All of these things, if we see any discrepancy, we need to tell the doctor immediately, because we need to get that blood flowing, because you will have tissue death. Now, cervical traction can be just the skin traction too, like this one here, or Crutchfield and Steinman is where metal tongs are stuck in. Now, Crutchfield is those little points that go into the head, and it pulls the cervical spine to keep it straight. The Steinman pin is what we used to use for fractured femurs, and it goes through the lower leg and it pulls it, again, doing the same thing, pulling that bone straight. And again, we're using Buck's traction now. I've not seen Steinman's in quite a while. Now, cerebral palsy, what is it? It's a group of disorders that affect movements and muscle tone or posture, which means they don't have control the way that they want to make their food and pick it up. They don't have that control. Their muscle tone can be weak. They have a hard time sitting. These children usually need to be strapped in, some of the more severe ones, into a wheelchair so that they're not just going to slip out. It's why what happens, well, there's some sort of damage, and it develops many times. I've seen it happen due to a hypoxic episode at birth. Maybe that child tried to come vaginally, got stuck. They had to run to the OR and do a C-section, get it out, but there has been a hypoxic moment. That's many times what I've seen with it. Now, sometimes we don't know immediately, right? So, and sometimes it was so brief, we didn't even think that there was this oxygen deprivation or anything. Or maybe it was some disorder that was there that we didn't know about. And now this is why we do those developmental checks, right? Growth and development. So we'll start to see in infancy, they're not rolling over when they should. They're not crawling when they should. They're not walking. They're not talking, and they're not grasping the way they should. These are things why when we see it, We need to tell our physician so that they can do early intervention, find out why, and then give them the tools, the speech, the physical, the occupational therapy. So, in general, cerebral palsy causes impaired movement associated with abnormal reflexes. They can either be floppy or they can have that rigidity, that spastic cerebral palsy, right? And it's abnormal posture, involuntary movements, unsteady walking if they can, or any combination of the above. So spastic CP, like I said, is increased muscle tone. It's like take your arms and tighten them up and they sort of shake. That's what spastic cerebral palsy is all about. You're going to see they're stiff and jerky and awkward movements. Their limbs are underdeveloped, and then there's increased reflexes in them. And this actually is the most common of all of them. Now, there's always questions about spasticity and athetosis. Now, spasticity is just tension in certain muscle groups. That's just, the arms when you move them, it's the arms, they're spastic because, they're tight, all right? Now, athetosis is involuntary, purposeless movements that interfere with a child's motion. You could see it could be the hands and moving, they're trying to get there, and they didn't do it, it just happened, involuntary. There's no reason for it. You can't work with it. Purposeless, okay? And opsynthetosis is involuntary arching of the back. So this is a child who's laying on their side, and all of a sudden their head rolls back and almost touches their butt. And I've seen it almost touch their butt. And it's this big muscle contraction that causes this to occur. Now, child abuse. We talked about those fractures, right? Well, what can cause whoever, a parent, or the child abuser, what would happen that caused them to abuse a child? Well, they could be in poverty, unemployed, or their function is just their family is just completely dysfunctional. You don't see love or hugs. Their children young are left on their own to do what they want because nobody's watching them, etc. The child, if it's disabled, can cause a parent or caregiver, to abuse them because they're hyperactive, they're temperamental, they're need extra special patience to work with those children due to one of these things. For instance, what about an autistic child who's extremely hyperactive? That sometimes can force a person over. And then sometimes it's because it's a foster child or a stepchild. They tend to abuse them more than their own. Now, parental stress is what if the parent was abused as a child? What if they don't like themselves and they got that low self-esteem? What if they're just overwhelmed with life? They're overworked, they're, overwhelmed, they have no time. That could cause them to react and abuse children. Uneducated, and then that substance abuse, alcohol, drugs, whatever that substance might be. So, what can trigger child abuse? Well, you're have a child who needs to be disciplined, time out, whatever. They've done something wrong. Well, sometimes that discipline becomes more of abuse than just a discipline. Sometimes it's that family conflict that can cause them to, you're doing this and that, well, come here, and the kid gets in the middle of it, and then they get the abuse. Of course, substance abuse and always financial always causes that extra stress in the family and could cause child abuse. Now, what are types of child abuse? Well, emotional neglect, sexual, physical neglect, or abuse. Emotional is like, oh, you're stupid, you're fat, you got too many pimples, you're dumb. That really will, after a while, if it's said all the time, is abuse. Emotional neglect is when you don't get hugged, kissed, you're not talked to, you're not paid attention to. It's, you have absolutely nothing. Sexual abuse is acts performed on a child for sexual gratification for the adult. And it's done in all different ways. I could go on and on. I've seen a few of them in my life. Physical neglect. And this probably was the hardest child abuse case I saw. It was a physical neglect where the father had locked his 7 or 8-year-old son in a room, tied to a bed, and didn't provide nutrition for and on just a mattress, and didn't feed him. And when he came into the ER, he was on his last breath, and we had to resuscitate him. And the good news is the child made it. And that father was placed where he needed to go. But that's physical. He didn't get anything. It's emotional, physical, it was everything there. And then, of course, the physical abuse, deliberate infliction of injury, belt buckles, cigarette butts, cigar butts, burning them with it, all of those things. So remember, there's dosage calc. If you have not received the dosage calc example for exam 2, send me a message. I'll send it to you. Not a problem. It shows you sample type questions. And I wish you all the best. Thank you for coming, spending your last almost hour with me. Is there any questions by anybody?